So far, we described the HIV life cycle and the mechanism of action of antiretroviral agents. Now, given a treatment-naive HIV-1 patient, recommend DHHS guideline-concordant antiretroviral therapy. Let's take a look at some reliable resources. For HIV infection and anything that's associated with HIV, such as opportunistic infections, we use in the United States the DHHS guidelines. So the DHHS stands for the Department of Health and Human Services, and their guidelines actually updated at least a couple of times a year, and they are available online. So they have several guidelines. They have one for HIV-1 for use of antiretroviral agents in HIV-1 infected adults and adolescents. They have one for pregnancy. They also have a couple on pediatrics. The focus of this presentation is on adult in HIV. They also have a guideline for pre-exposure prophylaxis and a couple on post-exposure prophylaxis, along with CDC guidelines for diagnosis of HIV. Let's take a look at diagnosis of HIV. These are the recommendations from the 2014 CDC guidelines. Since 2014, it's been recommended to use an assay that's a combination of antigen antibody, and these are antigen and antibodies from both HIV-1 and HIV-2. And if this does not test positive, so if it's non-reactive, now assuming that the patient has not had a risky behavior in the previous 15 to 20 days, then we can confidently conclude that the patient does not have HIV. And this test has a very high sensitivity and specificity. It does take some time for the body to make antibodies and for the antigen levels to increase in the plasma levels. Therefore, if someone has just been exposed to HIV, this test is unlikely to detect it. Now, if someone does test positive, we don't know if it's HIV-1 or HIV-2. So therefore, we need to do another assay, which is an antibody differentiation, to figure out if this is HIV-1, HIV-2, or both. If antibodies for HIV-1 are detected but not HIV-2, we can conclude that the patient has HIV-1. If the antibodies for HIV-1 are negative but HIV-2 is positive, we can conclude that the patient has HIV-2. If both of them are positive, then the patient actually is co-infected with HIV-1 and 2. And if neither of them test positive, now we have a problem, because initially the antigen antibody tested positive, but now we didn't find HIV-1 or 2. Now, to resolve this issue, we actually need to do nucleic acid test. A nucleic acid test is a lot more accurate because instead of antigen or antibody, it actually detects the HIV RNA. So if this tests positive, then we can conclude that the patient has HIV. And currently in the US, HIV-2 is not common. So the nucleic acid tests that are FDA approved are only for HIV-1. Now, if this patient does not test positive, we can conclude that the patient does not have HIV-1. And this is assuming that the patient did not have risky behavior in the past week. So it typically takes about 6 days for the RNA levels to go high enough for this test to actually detect it. This nucleic acid test is a qualitative test, so it basically tells you if the RNA is there or not. Regardless, when someone is tested positive, we actually need to do PCR in order to quantify the viral load. The primary reason that this algorithm exists is because these antigen antibody assays are actually more affordable than the nucleic acid test. So if you're using it for screening purposes, where majority of patients will actually be non-reactive, this is a more cost-effective way of screening people. And then people who test positive will actually end up with more tests and possibly nucleic acid tests, which are more expensive. Let's take a look at HIV serology profile. So here on the x-axis, we're looking at time in units of days from the time of HIV infection. So you can see that when someone gets infected, it takes some time for RNA levels to become detectable. And as time goes on, as technology advances, our assays actually become better and better. So with the current nucleic acid test that we have, it can actually detect it a little sooner, about 7 days. But you can see this figure is from the 2014 CDC guidelines that they say about it takes about 10 days for RNA levels to be detectable in plasma. And this would be, so in order to detect this RNA, we would have to use nucleic acid test, which is the most expensive compared to the other assays that we have. Now, as time goes on, as we approach about, let's say 15 to 20 days, that's when the P24 antigen becomes detectable. And that's why we use these fourth generation antigen antibody assays to detect it. So, if somebody gets, tries to test, within a week, this test will of course test negative. So that's why it's important to know when the patient got exposed and wait about between 15 to 20 days to use this test. And then what takes the longest is for the body to actually make antibodies. So, and this typically takes about, more than 25 to 30 days. Now, in the old days, we had assays for antibodies, so we typically had to wait, at least 3 to 6 months to test patients. Nowadays, because we have these fourth generation immunoassays, we can actually test pretty early within 3 weeks of exposure. Whereas you can see some of those older first generation assays, you typically had to wait about 3 months. So when should treatment be started in patients with HIV? Now, in the old days, it used to be that the recommendation was based on the CD4 count. So patients who had lower CD4 count, they were at higher risk of having opportunistic infections, cancer, and of course mortality. So and of course older HIV drugs were very toxic, so we would actually reserve it for more severe patients. But nowadays HIV drugs are very effective, they're very well tolerated, and we have clinical evidence that regardless of CD4 count, when we start treatment for HIV, we can actually reduce the rate of morbidity and the rate of mortality associated with HIV infection. And this mortality could be due to cardiovascular disease, it could be due to cancer, it could be due to opportunistic infection. So it actually can be significantly high. And HIV treatment can actually reduce these numbers significantly. So that's the most important reason to start patients on HIV treatment as soon as possible. And I'll talk about some of the things that we should actually make sure of before we start treatment. And of course, the other issue is transmission. And we do have very good evidence that once we start treatment, HIV transmission will be significantly reduced. And this transmission could be to sexual partners, as well as vertical transmission from infected mothers to the infant. One thing that's very important is adherence. So although we want to start HIV treatment as soon as possible, note that this doesn't say immediately. We want to do it as soon as possible, but we got to make sure that the patient is actually ready to start treatment. So we want to make sure that the patient is aware that this is a lifetime commitment to treatment. We want to make sure that they are aware of adverse effects and how it's going to affect their life. There's some stigma associated with HIV and HIV treatment, and we want to make sure that the patient has access, to these drugs. Payments would be very important. In order to optimize adherence, because once we start treatment, it's important to have continuation, because if there are interruptions of treatment, the virus can easily develop resistance to HIV treatment. Here are the goals of therapy with ART or antiretroviral therapy. It's important to note that interruption of therapy has been associated with rebound viremia. And it can in fact worsen the immune function once the viremia rebounds, which can in turn result in increased morbidity and mortality. So the guideline does recommend that once ART is initiated, it should be continued with 4 specific goals. So we want to maximally and durably suppress the HIV RNA in the plasma. We want to restore and preserve the immunologic function, which is basically the CD4 count. And we want to reduce HIV-associated morbidity and prolong the duration and quality of survival. And of course, prevent HIV transmission. if someone is at risk of transmitting it. So for example, transmitting it to infants, for those who are, for women who are pregnant, and of course to partners through sexual transmission, as well as other risky behaviors such as sharing for injection drug users, for sharing needles, for example. Now, the current ART are so effective that once we start ART, the patients are expected to have undetectable viral load within 12 to 24 weeks, or basically 3 to 6 months. The recommendations in this guideline apply to non-pregnant patients. There is a separate guideline for pregnancy. Regardless, it is important to do a pregnancy test prior to initiating antiretroviral therapy, because recommendations for pregnancy are different because of some of the toxicities of the drugs that could affect the infant or fetus. Now, generally speaking, majority of first-line regimens that are recommended follow this rule that you need a backbone plus a third agent. So we use 2 NUCs, or 2 nucleotide reverse transcriptase inhibitors as a backbone plus a third agent. So it's important to have this combination in order to prevent HIV from developing resistance. And generally speaking, we have 3 backbones that are commonly used. So we have Epzicom, which is a combination of Lamivudine and abacavir. We have Truvada, which is Emtricitabine and tenofovir disoproxil fumarate. And we have Descovy, which is a combination of Emtricitabine and tenofovir alafenamide. And I'll explain what's the difference between tenofovir disoproxil fumarate and tenofovir alafenamide shortly. Now, Lamivudine and abacavir are 2 NUCs that are commonly used in combination in Epzicom. So this will be 1 pill that would be used as a backbone. So if you are to use Epzicom as the backbone, you still need a third agent to go with it. Between Lamivudine and abacavir, Lamivudine also has activity against hepatitis B. Abacavir does not. So it's important to make sure that you are aware whether the patient also is co-infected with hepatitis B. Because, for example, if we are using something that covers hepatitis B and then later you decide to switch it to something that does not cover hepatitis B, the patient can have reactivation of Hep B and possibly Hep B flares, which could potentially be fatal. Now, all of these drugs in this class of NRTIs or NUCs, because they actually are analogs of nucleic acids, that means that any RNA or DNA transcriptase can or polymerase can actually use this. So especially with the older NRTIs that we no longer use, they had an affinity for human mitochondrial DNA. And because of that, they were associated with lactic acidosis. And this became a black box warning, which, for the entire class. So these new drugs that we use, or I should say relatively newer, compared to the drugs from the 80s, these have lower affinity for mitochondrial DNA, and therefore they are not likely to cause lactic acidosis. But regardless, the FDA has this black box warning for all NRTIs. One thing that's specific with abacavir, before anybody can be started on abacavir, we should actually do a genomic polymorphism test of HLA-B5701, and you should only start abacavir if someone tests negative for HLA-B5701. And that's because people who test positive for HLA-B5701 are at least they have a at least 50% increased risk of having fatal hypersensitivity reaction to this drug. So it's crucial to test this before starting abacavir. So that becomes one of the limitations of using abacavir, because you cannot. So if somebody tests HIV positive and you want to use this, You have to order this test, and it typically takes a few days, around a week to come back. So it kind of delays therapy, but some patients may have no other option, so we have no choice but to test this, and then once they test negative, we can start a regimen that includes abacavir. Now, all NRTIs are renally cleared except abacavir. So abacavir is actually cleared hepatically, so you may need to dose adjust it in patients with mild hepatic dysfunction, whereas all other NRTIs actually need to be renally adjusted. So, for example, Lamivudine, creatine kinase cutoff is 50. Now, as a class, all NRTIs can cause nausea, vomiting, headache, rash, and increased liver enzymes. Lamivudine specifically is very well tolerated in general, but it does cause in some patients fatigue and insomnia. Abacavir, of course, can cause hypersensitivity reaction, especially if patients have HLA-B5701. So HLA-B5701 positivity is a contraindication, and of course it can also cause fatigue. Now, when it comes to the other combinations for the backbone, we have either Truvada or Descovy. So Truvada was their first, which is a combination of Emtricitabine and tenofovir disoproxil fumarate. And these two combinations, both of them cover hepatitis B, and of course they still have this lactic acidosis black box warning, which all NRTIs do. And both of them are renally cleared, so creatine kinase cutoff of 50 for these two. TAF, or tenofovir alafenamide, is a newer formulation of tenofovir, which is actually creatine kinase cutoff is lower, so you can actually still use it in some patients with CKD. Generally speaking, these drugs are very well tolerated. Emtricitabine specifically can cause hyperpigmentation. TDF can cause nephrotoxicity and bone mineral loss, and this in fact is the reason that we actually came up with a new formulation of tenofovir alafenamide, which still does have nephrotoxicity and bone mineral loss, but it's significantly less compared to TDF, and I'll explain that more. Now, note that this tenofovir does not cause bone toxicity in the sense that it does not cause bone marrow suppression. It just causes some bone mineral loss. So this is not the same as bone mineral suppression. This just increases the risk of osteoporosis. Now, let's take a look at the difference between TDF and TAF. So tenofovir itself is the actual drug. Tenofovir is the actual drug that's an analog of a nucleotide, and that's what needs to go inside the target cell to block HIV replication. The problem is when you orally take tenofovir, it's actually not absorbed. So this part is the GI tract, and when you take a pill of tenofovir, you would like it to be absorbed and go into the blood, and then the blood, in the circulation, HIV actually is inside the CD4 cell. So the target cell is the CD4 cell. That's where HIV replicates. You want this tenofovir to be absorbed into the blood, and then from the blood to go to the CD4 cell, and then find the HIV virus and block its replication. The problem is tenofovir is not absorbed. So we had to do something. We had to come up with some sort of salt formulations that increases absorption. And that's why we had TDF. So tenofovir disoproxil fumarate actually gets absorbed from the GI tract. So if you were to give 300 milligram, it gets absorbed. And then a tiny portion of what gets absorbed goes to the target cells, CD4. Okay, and that's how much we need in the CD4 in order to prevent replication of HIV. Now the problem is the majority of this tenofovir is staying in the plasma where we don't need it. And guess where it goes? It goes to the kidneys. It's gonna go to the kidneys, and it's gonna cause nephrotoxicity. It's also gonna go to the bones and cause bone mineral loss, things that we do not like. So This has become a problem because patients need to be on these drugs for life, and over time this can build up, and patients will have start to have CKD, or if they already have CKD, the CKD will progress. And as we all know, as we age, we also are all susceptible to bone mineral loss due to just aging, and this will actually accelerate it. So people who have HIV and are aging and are on TDF, they actually will lose more bone mineral. So we came up with TAF, which is a different salt form. So it actually absorbs. So when you take this orally in the GI tract, it gets absorbed. Now, majority of this goes into the target cell, so you get the same amount in the CD4 where you actually need it, and then a tiny portion of it stays in the blood where it's gonna go to the kidneys and it's gonna go to the bones and it's gonna cause some toxicity. But because this is a significantly lower concentration in the blood than compared to TDF, it has significantly less nephrotoxicity and bone mineral loss, and therefore we're starting to use more and more TAF compared to TDF because the efficacy is the same, because you get the exact same amount in the CD4 cell, and that's exactly why you see a huge difference in the dose. So TDF you need 300 milligram, and TAF you need 25 milligram in most regimens, unless you have like a inhibitor where you would use a 10 milligram. So if you have cobicistat in the regimen, for example, you will see 10 milligram. So here are the recommendations for most people living with HIV. So green means first line recommendation, yellow means alternative. So these are for people who cannot tolerate the first line. So in certain situations, these yellow ones are recommended. Now, these recommendations are for general population with HIV. These recommendations do not apply to pregnancy, and they do not apply to people who also have tuberculosis, because as you will learn later, regimens that are used with tuberculosis, specifically rifamycins, can cause a lot of drug interactions, so the recommendations are slightly different. Now, generally speaking, for the first lines, we want to use integrase strand transfer inhibitor. So you can see all of these are integrase inhibitors plus a backbone. So the integrase inhibitor is your third agent, and you need a backbone to go with it. So the first one is bictegravir as the third agent, which is an integrase inhibitor, and then your backbone is the emtricitabine and tenofovir, which are 2 nukes. And this comes in 1 tablet. So anytime you see just a slash, that means these are all formulated in the same tablet. So the brand name is Biktarvy. Anytime you see a plus sign, that means there are 2 tablets. So dolutegravir plus emtricitabine tenofovir, for example, you have to give a pill Tivicay for dolutegravir, which is your third agent, plus your backbone. So the backbone you do either Descovy, which has the new formulation TAF in it, or you do the older formulation Truvada, which has TDF in it. It doesn't really matter which one you do. They're all first line. Of course, if you want to consider the toxicity, you might prefer to do the Descovy because of the improved tolerance when it comes to nephrotoxicity and bone mineral loss. Now, dolutegravir does come as a single tablet regimen with a backbone of abacavir and Lamivudine. The problem with abacavir is that, as you can see with the asterisk here, you can only use it if it's HLA-B5701 negative. So if you were to use the pill Triumeg, you gotta wait for this test to come back and only start it if it's negative. So if this is positive, then you gotta, instead of this, you gotta use dolutegravir plus a different backbone. Another option is raltegravir, which is an integrase inhibitor plus a backbone of emtricitabine and tenofovir. And this is first line. You get 2 tablets. Now, if you wanted to use a different backbone that has abacavir, this is actually considered alternative. So, this is primarily not only because for abacavir you need to get the HLA-B5701, but it also makes it more complicated because with this regimen you should only use it if the HIV RNA level or the viral load at baseline is less than 100,000. And that's because if the viral load was higher than 100,000, this combination with this backbone is not as efficacious. So therefore, because we have so many other options, the guideline says don't worry about it, use something else because they're better. And of course, the last integrase inhibitor we have is elvitegravir plus cobicistat plus emtricitabine plus tenofovir. So this comes in a single tablet. This is no longer a recommended first line. It used to be, a couple years ago, this was first line. The reason it's no longer first line is because this cobicistat. Cobicistat does nothing to the HIV. The only thing it does is that it's a CYP3A4 inhibitor, and what it does is that it actually boosts the level of elvitegravir. So elvitegravir is a substrate of CYP3A4, and it has a very short half-life. In order to make the half-life longer, we actually use cobicistat to prevent its metabolism. So therefore, you can still give this whole regimen once a day instead of multiple times a day. Now that worked all well. The problem is that anytime the patient is on something else that's a substrate of CYP3A4, it's gonna cause a lot of drug interactions. And oftentimes contraindications. And because that's a hassle, that's a headache, and we have a lot of other regimens that are very effective. So the guideline said don't worry about it, use something else that's more effective because this is unnecessary headache. Now, if somebody couldn't tolerate other, some of these other first lines, it's absolutely okay to use it. You just have to check for drug interactions, which we will actually look at shortly. So all these top sections were integrase inhibitors. Then we have protease inhibitors. Protease inhibitors, they all have to be boosted, just like elvitegravir. All protease inhibitors, in fact, there are only 2 of them that we use. There are many more protease inhibitors that we no longer use. Darunavir and atazanavir are 2 that we still use, but they're not first line because of the same problem. There are lots of drug interactions. So these can be either boosted with cobicistat or with ritonavir. So ritonavir is also itself a protease inhibitor, but we use it as a small dose that it doesn't really do anything to HIV, but it's such a potent CYP3A4 and many other CYP enzymes that it inhibits. It's considered a very strong booster. And in fact, the reason we came up with cobicistat is because it's more selective to CYP3A4 compared to inhibiting every other CYP enzyme that exists. So it actually has, cobicistat has fewer drug interactions compared to ritonavir. Okay, and then we have non-nukes as the third agent. So the non-nukes or NNRTIs, we basically use efavirenz, relpevirin, and doravirin. Doravirin is a pretty recent approval. It got approved last year, or actually earlier this year. So these are actually alternative for many reasons. Efavirenz, for example, is associated with psychiatric adverse effects, specifically suicidal ideation. So because a lot of people attempted suicide using, when they were on this combination, it's actually not recommended first line. It's very effective regimen, but suicidal ideation is a serious adverse effect, and because we have so many other regimens that are well tolerated, it's no longer recommended first line. And then we have relpevirin as the third agent, which is no longer recommended first line, and it's again because you have to use it only when the viral load is less than 100 and the CD4 also needs to be 200. And that's because when the CD4 was less than 200 or when the viral load was greater than 100,000, relpevirin was not as effective. So because we have so many other regimens that are very effective, the guideline says don't worry about it, just use something else. Now, if somebody couldn't tolerate those other regimens, it's absolutely okay to use this, but as long as the patient meets these two criteria. So if the CD4 is less than 200, you cannot use this combination of rilpivirine, emtricitabine, tenofovir. And lastly, we have regimens to consider when abacavir, TAF, and TDF cannot be used. So of course, abacavir cannot be used if someone has HLA-B5701 positive. It's also associated with cardiovascular disease. So if someone does have underlying cardiovascular disease, it's also not recommended to use abacavir. And with TDF and TAF, you know, patients, especially older patients who either have osteoporosis or they have CKD or both, these are not the best things to use in them. So they say, you know, we might have better options. So Dovato, which only has one agent as the backbone, so this is in violation of the general rule that you want two NRTIs as the backbone plus a third agent. This actually has one agent as the backbone plus dolutegravir, and this actually is very effective. So because this is relatively new, so you know, evidence for its use is still limited because it just recently came to the market. So that's why it's you know, it's alternative for now until we get more data for it. But it's actually very well tolerated and very effective. So you can actually use this as initial therapy if you know, if you have reason that your patient should not get abacavir, TAF, or TDF. And there are some other you know, protease inhibitor darunavir regimen that you can use alternatively, and these pretty much violate the rule of you need two NRTIs as the backbone.